Good morning, students. Today we are going to learn about organ transplantation in details. So organ transplantation can effectively restore vital organ function in patients who are suffering from a variety of medical disorders. In some situations, organ transplantation is the only available option and essential for survival. And in other situations, it offers the potential for improved disease control and better quality of life. Kidney, heart, liver, lungs, small bowel, bone marrow, and composite tissues like skin, muscle, tendons, nerve, bone, blood vessels may be considered for transplantation. So, in some situations, organ transplantation is the only available option and is essential for survival. In other situations, it offers the potential for improved disease control and quality of life. Essential principles of organ transplantations they involve immunology, underlying for proper donation and recipient matching, need for immunosuppressive therapy for prevention of and management of graft rejection. Bone marrow or hematopoietic cells transplantation is a unique in that there is no sophisticated surgical procedure, but rather a cellular infusion of hematopoietic stem cells. Rather than risk long-term chronic graft rejection, the major immune-mediated complication is graft versus host disease, in which the engrafted donor immune system attacks the recipient host tissue in an autoimmune-like manner. Solid organ transplantation is limited primarily by the availability of organ donors and limitations in organ procurement from cadavers. In some cases, organs are obtained from living donors, primarily with the renal and hematopoietic cell transplantation, but also with never approaches to partial pancreas and liver transplantation. Organ transplant recipients require comprehensive dental screening and clearance prior to transplantation to reduce infection risk. These patients have unique oral health considerations that are largely related to the administration of immunosuppressive medications and corresponding long-term immunosuppression. The dentist must understand basic principles of risk assessment and dental treatment planning prior to organ transplantation to be able to provide safe and appropriate long-term comprehensive oral healthcare management in the post-operative settings. Major advances in the organ transplantations have been facilitated by improved understanding of and improvement in the mechanisms for donor-recipient matching, development of effective immunosuppressive agents, improved surgical techniques, acceptance to the concept of brain death, transplantation of kidney, lung, heart, lungs, intestines, pancreas, and bone marrow may be considered a life-saving treatment option for selected patients with and organ diseases. Dr. Joseph Murray, a Nobel laureate, performed the first successful human organ transplantation in Boston in way back in 1954 using a kidney donated by the patient's identical twin brother. Today, over 10,000 renal transplants are performed annually in the United States and over 75,000 per year worldwide. The 1-year survival rate among renal transplant recipients is more than 97%, and the 5-year survival rate is more than 90%. Regarding the epidemiology, the first human heart transplant was performed in 1967. And at that time, the 1-year survival rate was only about 20%. The primary indications for heart transplantation includes severe cardiomyopathy, severe coronary artery disease, and congenital heart diseases. Nearly 2,500 heart transplant procedures are performed annually in the United States. Within a year, survival rate of 90% and 75% more than 5 years has been recorded. The first liver transplant was performed in 1967. Now more than 6,000 liver transplant procedures are performed annually worldwide. Clinical indications include extrahepatic biliary atresia, primary biliary cirrhosis, chronic hepatitis, that is HCV infection, advanced cirrhosis, sclerosing cholangitis, non-alcoholic steatohepatitis, alcoholic liver disease, fulminating hepatic failure, and hepatobiliary cancers. Survival at 1 year and 5 years is over 85% and 75% respectively. The first pancreatic transplant procedure, which also included a duodenum and a kidney, was performed way back in 1967 by Kelly and Lishi at the University of Minnesota in a patient with diabetic retinopathy, diabetic nephropathy. Approximately 1,000 pancreatic transplants are performed each year in United States. Taking into account all types of pancreatic transplantation, survival is over 96% at 1 year and over 80% at 5 years. Pancreatic islet transplant procedures as an alternative has shown considerable success. Lung transplant was first performed in 1963 and today is the standard of care therapy for selected patients. It remains a fairly high-risk procedure with a median recipient survival of just over 5 years. Indications include chronic obstructive pulmonary diseases, alpha-1 antitrypsin deficiency, idiopathic pulmonary fibrosis, cystic fibrosis, and idiopathic pulmonary arterial hypertension. Patients may be considered for single lung or bilateral lung transplant as well as combined heart and lung transplant. In 2000, the United States Center for Medicare and Medicaid Services approved isolated small bowel intestinal transplant combined with liver, intestine, and multivisceral transplant as a standard of care for patients with irreversible intestinal and parenteral nutrition failure. Survival outcomes are lowest in adult intestinal liver recipients with 1 and 5 year survival of approximately 69% and 46.1% respectively, and highest in pediatric intestinal recipients with 1 and 5 year survival of 89.2% and 81.4% respectively. Since 1957, bone marrow transplant has become a standard therapy for certain hematological disorders and malignancies. This procedure is more commonly referred to as hematopoietic cell transplant, that is SCT. The Center for International Blood and Marrow Transplantation reports nearly 8,000 allogenic SCT procedures performed annually in United States. Survival outcome varied depending upon underlying diagnosis, status at the time of transplant, donor type, and graft characteristics. Composite tissues that may be transplanted includes skin, mucosa, muscle, bone, and other structures. May be used to replace lost or dysfunctional anatomical structures. Composite tissue allotransplants has the potential to greatly improve recipients' quality of life. The first successful hand transplant was performed in 1998 and the first partial face transplant in 2005. This is a rapidly developing and yet still largely experimental procedure within the field with the highly variable graft survival outcomes. Now the etiology. Success in transplant medicine has been largely related to the advances in understanding of key clinical immunological principles of donor recipient matching, establishment coordination of organ donor networks, incorporation of standardized immunosuppression regimes, and improvements in supportive care. The most important aspect is donor recipient matching. Donors and recipients are matched using two different laboratory tests. First is HLA typing, antigen typing, which is the expression is determined on donor recipient leukocytes throughout the serological or more frequently DNA typing assays. The second test is serological survey, which functionally measures recipient's immune system response to exposure to donor cell antigens, and in case of SCT, donor immune response to recipient cell antigens. The immunosuppressant medications, even in matched related donor kidney and hematopoietic cell transplantations, non-specific immunosuppressive agents are necessary to prevent acute and chronic graft rejections. While effective at preventing and managing rejections, long-term administration of immunosuppressive therapies, including the recipient's susceptibility to infection and malignancy. Now the pathophysiology and complications. Complications associated with organ transplantation generally consist of graft rejections, problems that are related to chronic immunosuppressive therapy, and special problems specific to the transplanted organ. A potentially very serious complication of organ transplantation that can occur despite donor-recipient matching and the administration of immunosuppressive medications are hyperacute rejection of solid organs occurring within 48 hours of surgical anastomosis, acute rejection occurring within first 30 days, 90 days of transplantation, and chronic rejection of solid organs despite treatment with immunosuppressive medication is generally irreversible. Immunosuppression and infection risk. Immunosuppression medications non-specifically block T and B cell activity and innate immune effector cells and pathways, significantly increasing the risk of infection. Donor and recipient screening for major infections prior to transplant is essential to reduce the risk of infectious complications. Transplant recipients also receive extensive education and guidelines on other preventive strategies, including hygiene, environmental exposure, and food safety handlings. Most SCT recipients eventually have all immunosuppressive therapy discontinued. Those who develop graft versus host disease may require years of immunosuppressive therapy. Solid organ transplantation recipients require lifelong immunosuppression. Patients with chronic rejection or chronic graft versus host disease require more intense immunosuppression. Patients in the early post-transplant period are at the risk for nosocomial infections, opportunistic infections, and donor-derived infections. Invasive fungal infections tend to occur within the first 3 months of transplantation. Patients 1 to 6 months post-transplant face a high risk of opportunistic infections and reactivation of latent infections. Infections more than 6 months post-transplant tend to be typically community-acquired, but with more severe malformations. So other side effects of immunosuppressive medications includes immunosuppressive medications are associated with various side effects that can have significant medical implications. CNI therapy, that is cyclosporin and tacrolimus, is associated with the development of chronic kidney disease and renal insufficiency that can progress to end-stage renal disease. Other effects include tremors, magnesium wasting, hypertension, hyperkalemia, hyperuricemia, and hyperglycemia. Other side effects of immunosuppressive medicine includes mycophenolate is associated with myelosuppression and GI side effects. Azathioprine have a similar mechanism of action as mycophenolate, but is used less frequently due to its less favorable side effects. Prednisone therapy side effect increases with dose and duration and include hyperglycemia, hypertension, hyperlipidemia, and osteoporosis. mTOR inhibitors, that is sirolimus and everolimus, they are associated with cytopenia and hyperlipidemias. Cancer risk, there is increased risk of post-transplant lymphoproliferative diseases and non-melanoma skin cancers. PLDT incidence ranges from approximately 1% in renal transplant recipients and matched related unrelated SCT to 5% in liver transplantation. Management of PTLD includes reduction of immunosuppression and chemotherapy with an overall 5-year survival rate of only 40 to 60%. Risk is related to intensity and duration of immunosuppressive therapy and sun exposure. SCT patients are at increased risk for melanoma, liver, oral cancer, brain, thyroid, and bone cancers. Now, with coming up to the organ-specific complications regarding kidney transplantation, there is a particular risk for BK virus nephropathy. The risk can be distinguished from rejection by biopsy and is managed primarily with the reduction of immunosuppression. Renal graft rejection is monitored primarily by serum creatinine measurement rather than biopsy. If organ graft failure occurs, hemodialysis can be initiated. Now, with heart transplantation, cardiovascular diseases can arise from the donor heart due to pre-existing pathology, de novo related to traditional or existing existing risk factors, or from allograft vasculopathy. Symptoms of angina are typically not experienced. Therefore, requiring intensive monitoring for allograft vasculopathy by annual angiography is required. Recipients receive lifelong strain therapy regardless of lipid profile. In addition to surveillance by endomyocardial biopsy, rejection may present with typical symptoms of heart failure. With liver transplantation, in addition to graft rejection, recurring underlying diseases for which transplant was indicated is a potential serious complication in liver transplantation and can lead to transplant failure. Both HCV infection and alcohol abuse have high likelihood of recurrence and require routine screening and active treatment if detected. Now coming to the lung transplantation. Recipients may present with dyspnea, cough, and hypoxia. Lung function is monitored by spirometry with transbronchial lung biopsy performed as needed to rule out or to confirm acute rejection. Bronchiolitis obliterans, that is characteristic of chronic rejection, is less readily determined by transbronchial biopsy and is therefore diagnosed and monitored based primarily on spirometric measurements and changes over time. With hematopoietic cell transplantation, graft rejection is relatively rare in SCT due to effective immunosuppression. Graft versus host disease is potentially life-threatening, where engrafted donor lymphocytes mount a multifaceted alloimmune-mediated attack against the recipient host tissue. Acute graft versus host disease typically occurs within the first 100 days and after SCT, while donor graft versus host disease typically occurs after 100 days. Solid organ transplantation very rapidly involving graft versus host disease, though in facial transplantation, graft rejection of skin and oral mucosa presents clinically and histopathologically identical to graft versus host disease. The transplanted small bowel have anastomotic sites at the superior end of the navigated of the native GI tract as the jejunum, and at its distal end, a stoma is created exteriorly. The superior mesenteric artery is attached to the native aorta below the renal arteries. Now the clinical presentation. Transplant recipients, they generally have normal physiological function and performance status that is similar to the general population. If the graft takes with no chronic rejection or graft versus host disease. Depending on the degree and extent of organ function compromise, the clinical presentation of solid organs may resemble that of pre-transplant disease status. Signs and symptoms of graft versus host disease vary, but include skin rash, diarrhea, fibrosis, oral lichenoid inflammation, and sensitivity, and eye discomforts. Coming to laboratory and diagnostic findings, lab testing is critical for monitoring organ functions, metabolism of medications, and infectious diseases. Blood pressure is monitored at every visit. A lipid panel and a diabetic screening should be ordered every 6 to 12 months. Monitoring of serum creatine is important in renal transplant recipients to screen for rejection, as well as in all patients on CNIs and other immunosuppressive agents. Liver function test is routinely performed in liver transplant recipients as rejection causes elevated transaminase, bilirubin, and alkaline phosphatase. Pulmonary function is monitored by spirometry and indicated in lung transplant recipients as well as SCT patients and graft versus host disease or shortness of breathness. Pancreas transplant rejection may manifest with compromised endocrine function or an increase in amylase level. Surveillance needle biopsy is routinely performed for most solid organs to screen for rejection. Biopsies may be obtained weekly or monthly, early after transplant, and then less frequently. Graft versus host disease can generally be determined from clinical features, but involve tissue histopathology that may be helpful in supporting or ruling out the diagnosis. Cyclosporine, tacrolimus, sirolimus are monitored by routine measurement of serum levels. CMV reactivation is monitored at predefined intervals by quantitative PCR. Patients with invasive fungal infections are monitored via serum glucan and glucotamine antigen testing. Now coming to the medical and surgical managements. Medical management is based on principles of immunosuppression for prevention of management of graft rejection, infections, screening for and management of late complications. Medical and surgical management continues while with the immunosuppressive therapy regimes are similar. They vary based on the organ, patient-specific factors, and institutional preferences. In solid organ transplantation, this typically consists of triple drug therapy with corticosteroids, a calcineurin inhibitor, or a purine synthetic inhibitor. Anti-lymphocyte therapy may include as a part of the initial therapy or to manage rejection episodes. Sirolimus is variably used in some protocols, in particular to reduce their need for CNI therapy. In HCT and GVHD, prophylaxis regimes typically consist of a short course of methotrexate combined with CNI that is tapered over a period of 3 to 6 months. In most grafts, the pancreatic duct is drained into the bladder. Urinary amylase levels that 25% reduction are useful in patients with bladder drained pancreatic transplants to monitor the rejection. In patients who have simultaneous kidney and pancreatic transplants, an increase in serum creatinine indicates the possibility of onset of rejection before there are any changes in urinary amylase are detectable. First line therapy for rejection and graft versus host disease is corticosteroids, which with a single line, with a second line including rituximab, azimuthuzumab, extracorporeal photopheresis, and low dose IL-2 in addition to the medications already discussed. Management of relapses of underlying hematological malignancies after SCT includes rapid tapering of immunosuppressive therapy, donor lymphocyte infusion, which are both intended to stimulate a potent graft versus tumor effect, but also trigger development of graft versus host disease. Patients on immunosuppressive therapy are at high risk for a wide spectrum of infections. Infectious diseases prophylaxis strategies are based on known or likely exposure to infectious agents based on serological testing and epidemiological history, as well as intensity and duration of immunosuppression. Preventing strategies include vaccination, universal antimicrobial prophylaxis, and preemptive therapy. Regarding prophylaxis and preemptive therapy, active infections should be eradicated prior to transplantation and patients carefully monitored for evidence of deactivation. Of particular relevance from an oral health standpoints are guidelines related to herpes simplex virus infection and oropharyngeal candidiasis. Acyclovir prophylaxis is started at the initiation of immunosuppressive therapy for HSV seropositive patients, and it is continued for at least 30 days with variable duration based on types of transplant, intensity, and duration of immunosuppressive therapy and institutional protocols. Recommendations call for daily antifungal prophylaxis with fluconazole or liposomal amphotericin B for solid organ transplant recipients at high risk of candidiasis, and fluconazole, posaconazole, or mycofungin in SCT patients during periods of neutropenia. Recommended guidelines are available for long-term prevention and screening practices for organ transplant recipients. Some recommendations are organ and disease specific. Most are related to administration of immunosuppressive medications and are universal. These include guidelines that are related to immunity and infection, ocular health, oral health, pulmonary health, cardiovascular, hepatic, renal, and genitourinary health, musculoskeletal health, nervous system, mental, endocrine, psychosocial, and secondary cancer screening. Now, coming to dental management, due to a period of profound immunosuppression following a transplanted, it is a standard of care for all organ transplant candidates to undergo pre-transplant dental screening and clearance in order to reduce the risk of infectious complications. Patients should perform basic oral care to reduce the risk of inflammation and or local or systemic infections. Patients with a history of gingivitis or periodontitis may benefit from daily chlorhexidine gluconate rinsing, often included in the oral care regime, HSCT centers. Removal processes should be cleaned manually and soaked overnight in a disinfectant solution. There are no universally agreed upon indications for antibiotic prophylaxis prior to dental treatment in transplanted patients. American Heart Association guidelines that are recommended for dental patients are antibiotic prophylaxis in cardiac transplant recipients who develop vasculopathy. AHA prophylaxis regimes have also been recommended for patients on immunosuppressive therapy for dental treatment. American Academy of Pediatric Dentistry infection risk prophylaxis guidelines recommend prophylactic antibiotics for HA guidelines. The important aspects of assessing patient risk is knowing medical history and status, indications for transplantation, organ functioning status, current medications, pertinent laboratory results, and transplantation schedule and timeline. Patient may be at risk for bleeding due to antithrombotic therapy, anticoagulant therapy, advanced liver diseases, or thrombocytopenia, and therefore they require special and careful evaluation of medical history and partial prothrombin time and thromboplastin time and a normalized INR. The objective of pre-transplant dental screening and clearance is to reduce the risk of infection in the immediate post-transplant period of immunosuppression. Dental screening is considered standard of care at all transplant centers to reduce overall infection. The pre-transplant dental screening should include a dental history, full mouth series of dental radiographs, viability testing, periodontal test, evaluation, assessment of third molar, treatment of all dental caries, management of pulpal infections, dental scaling and root canal planning, extraction of teeth with overall poor prognosis, and dental prophylaxis. Elective dental care is generally deferred during the immediate post-transplant patients period due to profound immunosuppression and risk for infection. Dental management of the patient post-transplant can be divided into three phases: immediate post-transplant period, stable graft period, and chronic rejection period. Once the graft is stable and functioning and any acute reaction has been controlled, the patient is considered to be in a stable phase. During this period, patients should receive routine dental care, including regular periodontal management, maintenance visits, and active management of any evident dental pathology. During chronic rejection or actively treated graft versus host disease, transplant recipients are again at significantly higher risk for infections. Patient's evaluation begin with a comprehensive medical history, review of current medications, and assessment of pertinent laboratory results. Oral mucositis is a complication unique to SCT and is related to both the intensive conditioning regime as well as the course of methotrexate given to these patients. Typically develops 7 to 10 days following initiation of conditioning and does not resolve until engraftment and resolution of a normal white blood cell count. Clinical features are characterized by diffuse non-specific erythema and ulceration of the non-keratinized oral mucosa, compromising oral functioning and quality of life. Aside from infectious complications, there are several potential oral complications associated with immunosuppressive medications that are used in transplantation. Gingival overgrowth, cyclosporin is associated with the gingival overgrowth. Gingiva appears edematous, swollen, and overgrown, often involving the interdentulous region and extending into the crown of the teeth. Management includes intensive periodontal care, improved oral hygiene, and surgery, that is gingivectomy. Tacrolimus is not associated with gingival overgrowth, and with the shift in the use of tacrolimus over cyclosporin, gingival overgrowth is now infrequently encountered in this population. Pyogenic granuloma. Tacrolimus has been associated with non-gingival soft tissue fibroinflammatory polyps, which closely resemble pyogenic granuloma. Symptoms are similar and typically associated with secondary trauma, while the pathophysiology mechanisms and relationship with the tacrolimus remains unclear. Management is simple surgical excision. mTOR inhibited associated stomatitis. In mTOR inhibitor therapy with the sirolimus and everolimus is associated with development of these painful abscess-like oral ulcers. They typically develop within first few weeks of initiation of therapy. Management with topical and intralesional steroid therapy is generally effective, although in some cases of mTOR inhibitor dose reduction may be considered. Oropharyngeal granuloma-like lesions. A typical orophyseal granuloma-like lesions have been described in pediatric solid organ transplant recipients who have received tacrolimus. Features includes multiple spherical nodules on the tongue, mucosal fissuring, and lip swellings. Then oral hairy leukoplakia is also known to occur with immunosuppressive therapy, and it is associated with Epstein-Barr virus replication and encountered in patients with immunodeficiencies. Biopsy is usually required for diagnosis. It is asymptomatic and usually does not require any treatment. Candidiasis. Potential risk factors for development of oral candidiasis in transplant recipients includes topical steroids, salivary gland hypofunction, and use of removable oral processes. Infections typically present with generalized white curd-like papules and plaques throughout the oral cavity. Diagnosis of candidiasis can typically be made clinically, but cytology or functional culture may be helpful when there is uncertainty. Systemic azole therapy with fluconazole is generally most effective. Herpes simplex virus infection. The risk of HSV Infection is so high that all seropositive organ transplant recipients receiving a cyclovir prophylaxis during periods of profound immunosuppression. Lesions present as very painful, irregular shaped, shallow ulcerations that can affect both keratinized and non-keratinized surfaces. Management includes use of therapy with acyclovir or Valsavir. Invasive fungal infections more frequently with aspergillus may present intraorally, typically in the maxilla as extension of pulmonary involvement. This infection presents as an ulcerated mass and requires biopsy for diagnosis. Management includes a combination of surgery and invasive antifungal therapy. Now coming to graft versus host disease. Graft versus host disease is a major complication of allogenic transplant and the leading cause of non-replaceable mortality. With chronic graft versus host disease, the oral cavity is one of the most frequently affected site and can be a significant source of morbidity due to oral discomfort. Clinical features includes oral mucosal lyconate inflammation with typical lichal planus like changes and associated mouth discomfort and sensitivity. Superficial mucosils are common features that are characterized by superficial salivary-filled blisters that develop primarily on the palate due to inflammation of minor salivary glands and do not generally require any specific therapy. And the lips are the most common site which are affected. Management of oral chronic graft versus host disease is directed at controlling symptoms and reducing the risk of complications. Oral mucosal disease can be effectively treated with topical steroids. All patients should see a dentist for cleaning and routine dental radiographs 1 to 2 times per year. Secondary malignancies. Oral transplant recipients are at increased risk for developing cancer. Patients with hematological malignancies who undergo SCT remains at highest risk for relapses of primary disease, typically within first 2 years after transplantation. Extramedullary disease can present in the oral cavity as a non-specific mass or ulceration. Risk of oral cavity and lip squamous cell carcinomas is increased significantly in post-transplant patients, with patients with graft versus host disease and SCT being at particular high risk. Oral SCC presents with the same clinical features in this population and in general population, but may be difficult to diagnose in the context of active graft versus host disease changes. Management outcome appears to be worse compared with non-transplant patients with oral SCC. Now there are frequent questions asked by the patients regarding organ transplantations. Have you received an organ transplant yet? If so, what organs? How long ago was the transplant? What medications are you taking? Have you experienced any oral changes or discomfort? Or so what symptoms? Do you know your most recent prothrombin time and INR? Do you know if you are required to take antibiotic pre-medication prior to dental treatment? If not, may call your primary care physician to ask some questions. So common healthy oral practices includes to educate the patient about the risk of staining, fluoride treatments, power brush to add in sufficient removal of bacterial plaque, flosses or floss picks depending on patient's preferences, dry mouth produce products such as biotin to reduce discomfort of xerostomia, provide patients with supplemental information on the importance of keeping the oral cavity free of bacteria due to their increased risk of infection. Mono or infectious mononucleosis refers to a group of symptoms usually caused by Epstein-Barr virus. It typically occurs in teenagers, but can also affect any age group. The virus is spread through saliva, which is why some people refer to as the kissing disease. Once you have an Epstein-Barr virus infection, you are likely to get another one. Any child who gets Epstein-Barr virus infection will probably be immune to mono or for the rest of their life. Thank you. Pause working and